Hello and welcome to the last lecture of the immunology course. I'm glad we made it to this point, and by this lecture I'm going to conclude by describing the new modalities in the treatment of autoimmune conditions, the different diseases that we talked about during this course. And so let's start by defining the immune-based therapy. In immune-based therapy, we rely on the immune system. So it's a treatment based on the action of the immune system to fight the disease. So it would either enhance the immune activity, increase the immune cells function to fight cancer, or on the other hand, it can also immune-based therapy can suppress the immune system, trying to reduce the activity of the inflammatory cells and inflammatory mediators to suppress or to improve the condition of autoimmune disease or inflammatory condition. Prior to immune therapy, steroids or corticosteroids were the mainstay therapy for all autoimmune and inflammatory conditions. Actually, and corticosteroids were only used by 1950, where the steroids, the three doctors who invented the corticosteroids and introduced the steroid therapy in the medical field, they were awarded the Nobel Prize. And since that time, steroids were the main or the cornerstone medication for all of autoimmune and inflammatory conditions. And actually it did a very good job. It made a huge difference in the quality of life and in the mortality rate of several severe autoimmune conditions like pemphigus vulgaris, for example, which used to be with a very high mortality rate because of the severity of the condition. With the steroids, this condition was able to be brought under control and improve the quality of life. Rheumatoid arthritis patients also were, the morbidity of the condition was so much decreased. It was amazing to see patients with rheumatoid arthritis are able to walk again and move again to suppress the severe inflammatory reaction they used to suffer from. So they relied a lot on using the steroids and treating the autoimmune and inflammatory conditions, and although it did a very good job, they started to notice lots of side effects by using the medication. Corticosteroids are very potent anti-inflammatory conditions because they work on several mechanisms. They block several points of inflammation. So in this image here, for example, it shows one of the mechanisms where corticosteroids conduct its action. So the first site of action is by inhibiting the rolling and inhibiting the adhesion molecules from being expressed on the endothelial cells, and this would reduce the rolling and adhesion of the neutrophils and reduce the amount of neutrophils that reach to the site of inflammation. So this is the first mechanism. But it's not the only one. It also acts on all forms of T cells, whether cytotoxic T cells, helper T cells. All of the T cells would be affected by the glucocorticoids, and their action would be blocked. It also affects the neutrophils, leading to a decrease in the number of the neutrophils. It affects the macrophages and induce changes in the macrophages so that they would become sort of suppressing cells rather than activating cells. So they will start producing interleukin-10 cytokine instead of producing interleukin-1 beta, which is a very potent pro-inflammatory cytokine, and TNF-alpha. So these cytokines will not be produced by the macrophage, and it will produce the interleukin-10, which would suppress further the B lymphocytes and the T lymphocytes. So it acts at different stages of inflammation to reduce the inflammatory response. Actually, we do like steroids, and usually for any autoimmune or inflammatory conditions, the doctor start with the steroid therapy for many reasons. The main one is its quick action. So it acts immediately. And I mean by immediately, like in 2-3 days, we can get a big action of the steroid therapy. This is a very short duration if we compare it with other immunosuppressants that we are gonna see later in the lecture. And other immunosuppressants, we require several weeks for the immunosuppressant action to start. So these are the let's say the good part or the good phase of the steroid therapy. But as I said, many side effects started to show up. So the patient become more susceptible to infection. Muscles would have sort of atrophy, and patient would develop different types of myopathies. Osteoporosis and osteonecrosis would develop. The patient would have a central nervous system symptoms and involvement. Also, the patient would be adrenally suppressed, so he is at high risk to develop a Addisonian crisis. Different metabolic changes, which is a major part of the side effects. Patients would be prone to hypertension, would be prone to diabetes, increased body weight, the change in the distribution of the fat. The GI would be affected, leading to gastric ulcer or irritation at least. The skin would also be affected. It will induce thinning of the skin and increase the hair growth in the skin. Increase the chances of developing glaucoma in patients. It would increase the cardiovascular risk of cardiovascular diseases. So lots of side effects, and this is why we cannot keep the patient on glucocorticosteroids. We usually start the patient on steroids and immediately start giving the patient other medication. We call them steroid sparing drugs, so that we would not have to stay on the steroids for a long time to prevent the development of all of these side effects. So what are other immunosuppressants? These immunosuppressants, they are more specific than corticosteroids. We've seen that steroids work at different levels and different mechanisms to control inflammation, which is a good part. But on the other hand, as the whole immune system is suppressed, including all the T cells, the macrophages, the cytokines, the antibodies, so this would induce a severe suppression in the immune system. So they thought maybe if we go more specific, we will have less side effects, and also the other immunosuppressant would not affect the adrenal hypothalamic axis. Also, the patient would not suffer from the metabolic effects of the steroids, like diabetes and hypertension. So these are the immunosuppressants, or examples of some of the immunosuppressants. One of them, or one category, is that which affect the T cells and inhibit the interleukin-2 synthesis, and the other is the one that inhibit the DNA synthesis. So let's look closer at these immunosuppressants. In the first example, the one that inhibit the T cell, so they, like cyclosporine, tacrolimus, and sirolimus, these medications, they affect the T cells, so the B cells are not affected, macrophages are not affected. It is more specific, and they work by reducing the interleukin-2 production. This is how they work. So this is the antigen presenting cells, and it presents the peptide or the antigen through the MHC molecule. And this is a T cell that has the T cell receptor, where it recognizes the MHC bound to the peptide. This is the first signal, and this is the second signal, the B71, that binds with the CD28 located in the T cells. As we get the two signals, this would activate calcineurin molecule, and this molecule would phosphorylate the NFAT, like dephosphorylate, sorry. So it will remove the phosphate group here. So we will have the NFAT that can get into the nucleus. NFAT is a transcription factor, so it will get to the nucleus and promote the synthesis of interleukin-2. So without going into these details, we know that when the antigen presenting cells contact the T cell, it will activate the T cell to produce interleukin 2. Interleukin 2 is very important in inflammation. It's known as a T cell growth factor. It is responsible for activation of the T cells, enhanced proliferation of the T cells, and differentiation of the T cells. So by enhancing when the T cell is activated by the antigen presenting cells, they will produce interleukin 2 that will activate this cell and will activate other T cells. What the cyclosporin do or the tacrolimus do, they inhibit the calcineurin. So they follow different mechanisms, but both of these medications, they just inhibit the calcineurin, and when the calcineurin is inhibited, NFAT cannot get into the nucleus and interleukin 2 would not be produced. So these medications, they just inhibit the synthesis of the interleukin 2 by T cells, and hence there would be no activation and no proliferation of the T cells. This is one example of immunosuppressants that act only on T cells, prevent their proliferation and activation by suppressing the interleukin 2 production. This is the second example of immunosuppressants. Now these immunosuppressants, they do not work on calcineurin, they do not affect the interleukin 2 production. They actually affect the DNA synthesis. So they would prevent DNA synthesis not just in T cells but in all rapidly proliferating cells. Example of these medications include azathioprine or Imuran and mycophenolate Mofetil. Now these medications, they reduce the number of the T, B and natural killer cells because they interfere with the DNA synthesis. So there's no DNA synthesis, no replication, no proliferation of these cells. And also, as the B cells are affected, there would be no antibody produced. This is azathioprine, cyclophosphamide and chlorambucil. Again, they also inhibit the DNA synthesis, and the way they do it is by alkylating the purine base. Remember, the DNA consists of A, G, C, T. These are the nitrogen bases of the DNA. So this cyclophosphamide, it binds with the purines, which are the A and G. So it binds with them and prevents the DNA synthesis this way by alkylating and by affecting these bases. So again, the end result is there is no DNA replication, so there is no proliferation of the T cells. This would again reduce the B and T cells, and it would reduce the antibody production. So does that mean these medications do not have side effects? No, they do have side effects. They do not have similar level of side effects like the glucocorticosteroids, but they do have their own side effects. Azathioprine, for example, which is responsible or which affects the DNA synthesis, and it will affect, as I said, all of the rapidly proliferating cells. So it's not just the the T cells and the B cells or natural killer cells. It also will induce a bone marrow suppression. So the patient is more susceptible to anemia, more susceptible to hemorrhage because of the suppression in the platelet synthesis. The patient might have hair loss again because of the decrease in the cell proliferation, because it affects the DNA synthesis. The main side effects that the patient would complain from are nausea and vomiting. Many patients cannot tolerate azathioprine or Imuran because of the nausea and vomiting side effects, although it is very severe at the beginning of taking the medication, but usually it subsides with time. Hepatotoxicity is another major side effect, and being an immunosuppressant, it will also have the side effect of developing opportunistic infections and malignancy. Cyclosporin, which affect the calcineurin, as we stated, it has sort of less side effects, but the main side effect for it is nephrotoxicity, and which will lead to hypertension. Neuropathy is another one, in addition to opportunistic infection and skin cancer. So still, we do have side effects caused by these other immunosuppressants, or let's say steroid-sparing drugs. They have less side effects than steroids, but still they do have their side effects. So now we are in the era of immunotherapy, or the biological treatment, and the aim of the biological treatment is just to go specific, go straight to the point where you want to have change. You want to make changes in the immune system and deal with the problem by doing as least damage as possible in the body. So this is the aim of the biologics. Of course, the progress of the biological treatment, it relies mainly on our knowledge of the molecular basis of the disease. Many of the pathogenesis scenarios are not really well known for autoimmune diseases. Remember, when we discussed several examples of autoimmune diseases, we could specify that, for example, rheumatoid arthritis, TNF has a big and major role in causing rheumatoid arthritis, but we did not have more details. In other, like for example, neurological conditions, we knew that it's the T helper cell that is hyperactive or overactive, but we did not know exactly the mechanism how the T helper cell, or the CD4 T cell, let's say, the CD4 T cell, how it affected the pathogenesis of the condition. So as we tend to learn more about the pathogenesis, the mechanism of the immunology or immune parts that are involved in the disease, we would be able to develop better biological medications. So what are the biologics? It is medications where preparation or synthesis, where these medications are prepared or synthesized from living organisms or their product, and this is why we call them biologics. So any type of biologic or any type of drug that include, for example, vaccines, include blood or blood products or blood components, cells or allergens or genes. So even DNA is considered type of a biological treatment. So anything taken from living tissues or living organism would be considered a biological treatment. This is a very rapidly evolving type of or topic where there's lots of advances every day on the type of medications or which medications that got approval, like FDA approval. So we need to keep up with these medications. So very frequently we get medications that gets to the market, and we need to catch up with these medications. So biological treatment, it has different classes. We have the monoclonal antibodies, fusion protein therapeutics, cytokines and their receptors, peptide immunotherapy, and intravenous immunoglobulin. So I will start describing each type, and at the end of the lecture I will give different examples of biological medications. The first type is monoclonal antibodies. What do we mean by monoclonal antibodies? So antibody, we know it. This is the antibody, and let's just make a quick revision of its structure. It consists of a heavy chain and light chain, and in the heavy and light chain there is a constant region and there is a variable region. Within the variable region there is a hypervariable region where the antigen binds to this hypervariable region. We call this region Fab, which means fragment of antibody, fragment for antigen binding sites. And we have this portion, which is called the FC portion, or the fragment of a crystallizable region. So the fragment crystallizable region here, this one, the FC region here, is the part that binds with the cell surface if it is in a bounded form, and the Fab area contains the antigen binding site. So this is the antibody. What is a monoclonal? Remember that each antibody has a unique antigen binding site, and each B cell would produce only one type of antibody, meaning that one antibody with a one specificity of antigen binding site. When we have a monoclonal antibody, it means that we have a clone, which means a collection of antibodies, but all of them have the same antigen binding site. In contrast, in a polyclonal antibodies, we have different antibodies, and each one has its unique antigen binding site. This is called a polyclonal antibodies. So, how can we get monoclonal antibodies? This showed us the technique used to get the monoclonal antibody. First, we need an animal like a mouse or a rabbit, and we inject, for example, the mouse with the antigen that we want to create an antibody for. So we inject this rabbit here with the antigen. After a couple of weeks, the rabbit will synthesize antibodies specific to these antigens. Now I need to get these antibodies. We'll get a spleen from this rabbit, and this spleen has lots of B cells, including the B cells with the antibodies that I want, with the specificity that I want. So the first or this third step is that I want of course these B cells, they have a certain lifespan. They can live 7 to 10 days, then they will die. But I want cells that live forever and can produce this antibody forever. To do that, I need to fuse them with immortal cells. The immortal cells are cancerous cells. So we can get a myeloma cancer cell, and we will put in this plate the myeloma cancer cells and the B cells, all of the B cells that I got from that rabbit. With time, these cells would be able to fuse together, which means that one B cell will fuse with a myeloma cell, so I'll have a hybrid cell. Of course, not all of the cells would be able to fuse. Some of the B cells would remain as a B cell, other myeloma cell would remain as a myeloma cell. Now, my job now is to separate these different types of cells and get these hybrid cells that can produce the antibodies and they can live forever. To do that, I put all of the cells that I got from this culture here, I will put it in a specific environment or a specific medium called HAT. In the HAT medium, only cells that produce antibody would be able to survive. So in this case, when I put all of these cells in the HAT medium, the myeloma cells that did not fuse will die. Only the B cells would survive because they can produce antibody, and the hybrid cells will survive because they are a hybrid of immortal cells, the myeloma cells, and hybrid of B cells that produce antibodies. Okay, so now I need to separate the mix of two, and it's very easy. Just wait for 7 to 10 days. The B cells will die naturally because they cannot live forever, and the only thing that I will have are the hybridoma cells. These hybrid cells which consist of the myeloma cells, which are immortal, and B cells that produce the antibodies. Now I have hybridoma cells with different B cell specificity. They can screen for the specificity and separate these antibodies or cell lines based on the type of the antibody they produce. And at the end, after isolation of the clones, I would put these immortal cells in a medium. So now I have a medium. Each one has a hybridoma cell that is immortal, that can proliferate and survive forever, and producing one single type, monoclonal type of antibody. So this is how I can get a monoclonal antibody. So as you can see, we relied on the mouse or on the rabbit to synthesize these monoclonal antibody, and so we started using these murine means from mice, murine monoclonal antibodies. The problem with the murines is when they were used, they induced allergic reaction and immune reaction for many patients, because it's a foreign antigen. I mean, this antibody does not belong to the human antibody reservoir or society, so it would be recognized as a foreign antigen. So because many patients developed allergic reaction, they start thinking to use the human antibody. Of course, it's not as simple as murine, because you need to use transgenic mice where you transfect or you take this antibody gene from the human and transfer it to the mouse. Now the mouse can produce this human type of the Fc region, but you can choose the variable region based on the antigen that you want. So we started to have sort of a chimeric type of monoclonal antibodies, and with more work in the lab, with more success, they start to use mostly human and just only the hypervariable region where they want the antigen specificity would be taken from the mouse, and eventually they managed to get a fully human gene produced antibodies. And so in a monoclonal antibody medications, we can recognize whether this medication is purely murine or is purely human or is a hybrid at different percentages based on the name of the medication. So you will notice that we have some medication ending with OMAB. MAB means monoclonal antibody. So if you hear the name MAB at the end of the generic name of the medication, MAB means monoclonal antibody. If it is OMAB, this means it's purely murine, and they are less frequently used nowadays because they are being replaced with MUMAB, which is fully human. ZOMAB and ZMAB, they are chimeric forms of monoclonal antibodies. Okay, why do we need monoclonal antibodies? It's a very lengthy procedure to synthesize monoclonal antibodies. What advantages can we get from monoclonal antibodies? The first use is for diagnostic purposes. So ELISA, where we target specific proteins, relies on monoclonal antibody. Diagnostic imaging, where we can use the monoclonal antibodies, for example, to detect or to target certain antigens, and it is recently being used for breast cancer screening, where certain antigens are being targeted with monoclonal antibodies that harbor certain radio-opaque materials that can be seen clearly in the imaging. Another use is immunohistopathology. In mucocutaneous conditions, we take a biopsy, and part of this biopsy is transferred through Meckel solution for immunofluorescent. In immunofluorescent, we know the antigen, so we create a monoclonal antibody that specifically binds with that antigen. And to be able to see it, we use fluorescent tag, so it is fluorescently labeled antibody. Another use is the immunohistochemistry, where again we know the antigen, and there's an antibody that binds to the antigen, so we create an anti-antibody that binds with the antibody, and this anti-antibodies is labeled with a certain material that conduct a chemical reaction that can be seen as a change in the color. So this is what I mean by immunofluorescent. So the antibodies, the fluorescently labeled antibodies, could recognize the antigens located in the basement membrane, and now it is clearly seen. This would confirm the diagnosis of pemphigoid. And this is an example of immunohistochemistry, where there is a staining here that we can clearly see indicates the presence of the antigen. We could see it because of the labeling with the monoclonal antibodies that harbor this catalyst that would conduct the chemical reaction. So these are the uses for diagnostic, and what I really want to focus on is their therapeutic applications. Monoclonal antibodies are used for different autoimmune diseases, for cancer treatment, and for drug delivery. Simply, for drug delivery, for example, to get the best result of any medication, you need the highest concentration of the medication to reach to the site of infection or to the site of the problem or of the lesion. So to get this drug to the site or to the target cell, we can bind it with a monoclonal antibody that recognizes a specific antigen located only in that target cell. So now when the patient takes the medication, these antibodies would go directly to the target cell, bind to it, and the drug will do its action. This is far much better than taking the drug that will float in the circulation and move to affect all of the cells, maybe having a negative effect on these cells, and only a small fraction of this drug will get to the target cell. This is one of the therapeutic applications of monoclonal antibodies. This is another example of monoclonal antibody use, where it is bounded to the TPA medication that converts the plasminogen to plasmin, which is needed to relieve or to release the fibrin present in the blood clot. So instead of having this enzyme traveling all over the circulation, I will get it directly to the site of the blood clot, where the TPA will do the function of converting the plasminogen into plasmin, and by that the blood clot would be dissolved. These are two examples of drug delivery to the site of disease. The other therapeutic applications in treating autoimmune diseases and cancer treatment, I will be presenting them at the end of this lecture, when we have different examples of medications used to treat autoimmune disease and cancer treatment. So I thought I would go on describing each type of the biologics, and then we will have at the end the different examples. So far I talked about one part, which is the monoclonal antibodies. We discussed how they are formed and what are the applications for the monoclonal antibodies. Moving to the second type, which is fusion protein therapeutics. In fusion protein therapeutics, we use the Fc part of the antibody, only the Fc part, and we fuse to it a protein that we need. This protein could be an enzyme, could be a receptor, could be a cytokine, any type of protein. It depends on the condition or that we want to treat. So this is an example. This is the full human IgG, okay, and this is the Fc part. I don't need the whole IgG. This is the part that I want, which is a receptor. So I want a receptor. So what will be done in fusion protein is to fuse this protein, the receptor, to the Fc portion, and this is the end result. So we will have the Fc portion and the protein, which is a receptor, that will have the therapeutic effect. Why do we need to bind? Why not to use just the receptor? Why we need to bind it with the Fc protein here, or the Fc portion of the immunoglobulin? because when it is bound to the Fc domain, this improves the drug biological activity, increase the half-life of the medication, maintain its level in the blood and in the circulation. So it has a very effective results than having just the protein without the Fc portion. Of course, when we want to fuse these two proteins, we do not work on proteins, so we do not attach the two proteins together. What we do is attaching the genes of these two proteins to have a chimeric type of protein. So for example, this is the DNA. This is the gene that produces, let's say, the Fc segment. So we insert to it the part of the receptor protein that we wanted to conduct the action. Now it is inserted in this clone, in this cell clone, and when the cell will do its job routinely as usual during the transcription, we will have a messenger RNA containing the two proteins, the hybrid protein, and when it is translated we will have the protein that consists of two parts. The one part is the Fc segment and the other part the protein, the receptor segment. So this is how fusion proteins are being made. We just have a cell line where we got the genes that are responsible for synthesizing the protein. The third type of biologics are cytokines and their receptors. We just simply use or synthesize a cytokine or synthesize a receptor to conduct the function that we need. Example of these therapeutic agents, we have anti-interleukin-1 receptor antagonist known as anakinra. Anakinra is a medication that is approved, FDA approved for rheumatoid arthritis, and what it does, this is an image of a patient with that has been for about 9 months on anakinra. She did not respond to any to steroid therapy or to any of the immunosuppressants, but she responded very well to anakinra. And as you can see, there's no swelling in the joints, no inflammation. So this is the first example of interleukin-1 receptor antagonist, and the anakinra will bind with the interleukin-1 and prevent it from functioning, so the amount of interleukin-1 would be reduced. We know that interleukin-1 is a very potent pro-inflammatory cytokine, and it's the one that initiates, as the beginning of the cascade of cytokines. So inhibiting the interleukin-1 cytokine would have a profound effect on other cytokines and other inflammatory cells. The second example is the interferon alpha therapy. And interferon alpha is approved for chronic viral infections and approved for certain malignancies like hairy cell leukemia, malignant melanoma, AIDS-related Kaposi sarcoma, and follicular non-Hodgkin lymphoma. Remember, we talked about interferon, and interferon, they are the proteins produced by the cell when they got infected with a virus. So this cell got infected with a virus. This would turn on SOS genes that would produce the interferon. The interferon products, they will bind with the receptors and the adjacent cells, and now these cells would synthesize proteins that has antiviral effect, and it will destruct the virus, so it will prevent the spread of the virus. So this is one of the mechanistic actions of interferon for treating resistant or chronic viral infections by having a huge amount of interferon, which will help the cells to produce this antiviral or block the virus spread. The second mechanism of interferon use is in treating the malignancy is activating all of the cytotoxic and B cells to produce more antibodies, enhance the cytotoxic T cells to do the cytotoxic effect and damage of the tumor cells, activating natural killer cells, enhancing the macrophage to produce stimulatory cytokines and suppresses the regulatory T cells. So this is how interferon act to treat the cancerous lesions. So this was an example of some cytokines and receptors used for treatment of different types of diseases. The fourth type is the peptide immunotherapy. And in the peptide immunotherapy, the aim was to reduce the amount or the size of the molecules used in the treatment. In monoclonal antibody, we need to use the whole antibody with the whole segment, the Fc segment and Fab segments. And the cytokine, for example, therapy or cytokine receptor therapy, we synthesize a protein that cytokine, either interleukin-1 receptor or the interferon alpha. So we synthesize the protein. So they thought if we can just go to synthesize a smaller size of the substance, this would reduce the immunogenicity of that substance, and still it would be effective as it will go straight to the site of action. So this was the aim of producing a peptide immunotherapy. I have a very nice example of a peptide immunotherapy. Here they synthesized a peptide bound to the MHC class 2. Okay, so the peptide that I am using is this part only. I do not need a cytokine, I do not need immunoglobulin. All what I need is this peptide. And they, to administer this peptide, they attach it to a nanoparticle. These nanoparticles are inert, they do not induce any allergic reaction to the body. So what would happen when these nanoparticles holding the MHC2 with a peptide, and we select the peptide to be specific to the T cell receptors that are hyperactive. So this would go only to the T cell that has a receptor, T cell receptor specific to this peptide. And because I know that these T cell receptors or these T cells are the ones that, causing the trouble and causing the autoimmune condition, I would target it specifically, and I will keep the rest of the cells, of the immune cells, B cells, natural killer cells, other T cells, in normally without affecting them. So this nanoparticle with the peptide and MHC2 would bind with the T cell receptor of the target T cell. What normally happens when an antigen presenting cell bind to the T cell receptor, there must be a connection through the T cell receptor. This is the first signal, and there must be a second signal. Here we do not have the second signal. When there is no second signal, remember we stated that this T cell will go into energy, which means sort of a dormant phase. It would not be activated, there is a failure of activation, and what would happen is that it would be suppressed. When this T cell is suppressed, it will affect the other cells by turning them off, so they would start producing. Now this is this T cell after being energetic, which means like suppressed. It would act like T regulatory cells, and it will affect the B cell, making it regulatory B cell, unable to produce antibodies, and also it will affect the antigen presenting cells, making them producing less amount of MHC class 2 molecules, doing less presentation of the antigens, and producing inhibitory cytokines like interleukin 10, and suppressing any activatory or pro-inflammatory cytokines to be produced. So this would suppress the inflammatory reaction. This is a very, this is a very nice example, and it's actually new method to target only not the whole T cells, but just a specific clone of T cells that found to be autoreactive, or that was found to be targeting self antigens. So all what we did is introduce this self antigen to bounded with the MHC class 2 to this autoreactive T cells, and we got it in anergic form where it is dormant and suppressive. This is an example of a peptide immunotherapy. The last example is the intravenous immunoglobulin, and this is simple. And the intravenous immunoglobulin, we just get all the types of immunoglobulins produced by thousands of human beings. So the way how they do it, they donate blood, and there's actually a nice video here on how the IVIG are being used. So with a donation, they can separate the immunoglobulins from different individuals until they get a massive amount of plasma, and they even separate the immunoglobulins from the plasma, so they get the plasma concentrate. Here it's not a monoclonal, it's a polyclonal, and it is actually containing massive amount of immunoglobulins with different specificities. They are used as a placement therapy for patients who are immunodeficient. They either genetically they do not produce immunoglobulins, which we call it a type of primary immunodeficiency, or maybe secondary immunodeficiency. They do not, for any reason, produce different types of immunoglobulins. So they provide these patients with either the whole types of immunoglobulins or specific type of the immunoglobulins that is missing. The other use is being used as immunomodulating agents for autoimmune or autoinflammatory conditions. It was found that IVIG is able to modulate the complement activation, suppress antigen presentation. It will saturate the FC receptors located in the macrophages, and this would inhibit the activation of the macrophages. And it will also suppress different cytokines and inflammatory mediators. The exact mechanism how IVIG are being effective is not known, but these effects were reported and confirmed in different studies. So these are the types of biological treatments that are available, or the main ones at least, and we'll go into some examples of biological medications or biologics. The first one is anti-TNF alpha. TNF alpha is a very potent cytokine, and it is involved in different in the pathogenesis of different autoimmune conditions like rheumatoid arthritis mainly, and also it is very effective against tumor because it has a tumor cytotoxicity. It will turn on the cytotoxic T cells to attack tumors. The anti-TNF medication, they bind to TNF alpha, leaving the TNF beta functioning and free. So it would not, the TNF alpha is the one that is associated with the increased autoimmunity, and this is why it is targeted by the biological treatment, and this would spare the TNF beta, so this would not induce significant or a major immune suppression. There are different types of anti-TNF alpha medications. They all are anti-TNF, but they have differences in their pharmacokinetics and their half-life, how effective they are, and they are FDA approved for rheumatoid arthritis and Crohn's disease. So this showed us this is an immunoglobulin, and it binds with the TNF alpha here. So when it is bound with immunoglobulin, the TNF alpha cannot bind with the receptor to conduct its function. There is different type of TNF alpha that is transmembrane, where it is located in the membrane. And even these transmembrane types of TNF are targeted by the immunoglobulins. They will bind with it and prevent their action. So it acts like a sponge that would take all of the TNF alpha and reduce the inflammation and inflammatory reactions induced by the TNF alpha. Different types, as we stated, of the anti-TNF. This is one example, infliximab, and as you see, Zimab, it means that it has it's a monoclonal antibody, and it is a mixed murine and a human. Adalimumab, and as it ends with Mumab, this means it's a human monoclonal antibody, and all are the same, all are anti-TNF. Etanercept, so it's not a monoclonal antibody. This is an example of a fusion protein. It is anti-TNF, and we have the Fc portion, and we have the receptor here, which is a TNF receptor. So it binds with the TNF and prevents its action. And this is a new one, which is certolizumab. So Zumab, which means that most of it is human, but it's pigol, which means that it has the PEG substance, which is the polyethylene glycol. The polyethylene glycol, it has several advantages. It increases the half-life of the medication, reduces the immunogenicity of the medication, and one great advantage of it is it does not cross the placenta. So if a pregnant female patient needs to take anti-TNF, she can take certolizumab pigol, as it does not cross the placenta. These are examples of the anti-interleukin-1. As we said, interleukin-1 is a very potent pro-inflammatory cytokines, and these are examples of the medications used to counteract the interleukin-1 action. The canakinumab, and this, so MAB, it's monoclonal antibody. OMAB means it's a human, and this antibodies, it binds with the interleukin-1 beta, so the interleukin-1 beta is not available to conduct its action. This is the anakinra, which we talked about, and anakinra is it acts as a receptor antagonist, so it binds with the receptor, and by that it will prevent the interleukin-1 to bind with that receptor, and this is a cytokine therapy. We have the Givokizumab, which is, so Zomab, most of it is a human, and again it's a monoclonal antibody that binds with the interleukin-1 beta, and here is an example of a fusion protein, which is rilonacept. So rilonacept, the word sept means like fusion protein. So this fusion protein consists of the Fc segment and a receptor that bind with the interleukin-1 beta and prevents its binding to the interleukin-1 receptor. So these are examples of different types of medications, all have the same action, anti-interleukin-1. Some of them are monoclonal antibodies, some are cytokines, and others are fusion proteins. So a patient might benefit from anakinra but might not benefit from rilonacept. So the doctor should not give up on this class of medication. For example, if he tried anakinra and it was not effective for that patient, he can use other class of medication, although they all have the same effect, which is anti-interleukin-1. Anti-interleukin-2 is a sort of interesting type of a cytokine. This cytokine is responsible for T cell activation, and it activates both the effector T cell, which is sort of the cytotoxic T cell, the helper T cell that activates the B and the other T cells, and also it activates the regulatory T cell, which tend to calm down and suppress the immunity. So you can think that it does sort of a contradictory function. In fact, the interleukin-2 is sort of a fine-tuned in the body, and there is lots of feedback inhibition mechanisms that control the level of interleukin-2. Interleukin-2 maintains the balance between the regulatory T cells and effective T cells, which is the healthy status of the immune response. Now, when in a case of a cancer, for example, there is a decrease in the effector T cells, in the cytotoxic T cells, and this is why the tumor managed to grow and proliferate, because the cytotoxic effect or the effector T cells were sort of reduced, and there is an enhanced activity of the regulatory T cells. In order to get this back to the normal balance, the patient can be given a high doses of interleukin-2. This would shift the balance back to the normal by increasing the effective or effector to T cells and reducing the amount of the regulatory T cells. On the other scenario, when there is a chronic graft versus host disease or any autoimmune condition, there is in fact an exaggerated effector T cell function, lots of cytotoxic T cells, lots of CD4 T cells effect, and very minimal regulatory T cell function. So I need to get this shift back to the normal, and they found giving a patient low doses of interleukin-2, small doses, and in a very slow, gradual manner, this would return this to the healthy balance. It will shift the Treg or regulatory T cells up, increasing the amount of regulatory T cells and reducing the amount of effector T cells. So treating both opposite conditions, cancer where there is suppression of immunity or autoimmunity where there is exaggerated immunity, can be conducted with the same medication, but the difference is the dose and the way the medication is given. And this is an example of interleukin-2 cytokine therapy, which is aldesleukin. So aldesleukin or proleukin, this medication, when given at a high dose, it will exaggerate or increase the effective T cells, increase their number, increase the effective T cells, the cytotoxic T cells, and it is used to treat cancer, different types of cancer, including melanoma and metastatic renal cell carcinoma. At low doses, it will have more of a regulatory T cell shift, and it is used to treat graft versus host disease and insulin-dependent diabetes mellitus, or the autoimmune type of diabetes. This list is for you to have a look and read. It gives you the names of the medication, their trade names, and the drug. The aim is not to memorize these drugs, but is to to see or trying to know the class of the drug based on the name, whether monoclonal antibodies or cytokine therapy or cytokine therapy or protein fusion therapy. See the different indications for their use, including SLE, Sjogren, rheumatoid arthritis. So these are the FDA approved indications. See also the different cells and different molecules that are targeted using these biologics. For example, rituximab, so ZMAP, it means it's a chimeric human monoclonal antibody, and it affects the CD20 protein. So there is lots of examples. TNF antagonists, these are the different types of TNF antagonists. The prices, the cost, this is one of the drawbacks of these medications, is the cost. It's really very expensive medications, and there is no guarantees that this medication would suit you. So you might, for example, start with etanercept. It costs $1,600, and you might use it for many months and then figure out that it doesn't work and you need to shift to other medication. So this is one of the drawbacks of these medications. But hopefully, as always, things start expensive, and as with the improvement in the techniques and the laboratory techniques, preparing these medications will become more easier, cheaper, and more affordable. So hopefully we'll go with the cost down. More examples of the biologics affecting the interleukin-1, affecting the T cell co-stimulation blocker, interleukin-6 and rank ligand. Remember, rank ligand is one of the medications that is used for treating bone metastasis, severe form of osteoporosis. And it's denosumab, and as the name mAb means, it's a human, or it's a monoclonal antibody, OMAB, so it's a human monoclonal antibodies, and these antibodies block the rank ligand, and as I said, it is used to treat bone metastases and severe cases of osteoporosis. Does that mean these medications does not have side effects? They are, so expensive, too fancy, lots of, steps in synthesizing these medications. In fact, yes, it does have side effects, and some of them are really serious side effects. The main one is allergy or hypersensitivity reactions. So some patients develop, great allergic or significant allergic reaction at the site of the injection. Although it is specific, it's more specific than steroids, but still it suppresses the immunity, which increases the risk of infection and increase the risk of cancer. Although some of these medications are actually used to treat cancer. So there is sort of selectivity of a certain medications, which medication to use, which medication that would suit the patient better, or target the problem in a better way. It also has CNS symptoms, including sudden vision loss, numbness, tingling, cardiac reactions. One of the major drawbacks, one of the major side effects that might result from some of these medications. Lupus-like syndromes, capillary leak syndromes, where the capillaries tend to become more leaky, allowing more plasma to go out of the circulation, which lead to increased viscosity of the blood, and in turn will increase the chances of cardiovascular problems, and also will induce edema and severe hypertension. So still, although these medications are more targeted, but still side effects do happen, and they are actually prescribed by specialists in the field. Rheumatologists are the main ones who would prescribe these medications. GI specialists treating autoimmune diseases, Crohn's disease, for example. So still time would clear out different types of medications. All are biologic medications that have hopefully higher specificity, less side effects, and less cost for the patient. So this was the last lecture. Hope you enjoy the course, and hope you found it beneficial for your career, that it gave you more depth in your thinking of the diseases that you might study or you might face in the clinic. Thank you very much, and bye-bye.